So we are starting the spring session of FRCS Viva 2022. We have got a trainee who has agreed to record this Viva training session. This is very helpful for the revision as well as for the other trainees. So we shall go straight away to the Viva scenario. So today we are going to discuss the male LUTS in detail. So shall I start now?
Yeah.
You are referred, or your GP referred to you, a 62-year-old gentleman with severe LUTS of almost 1 year duration. The GP initially advised him lifestyle changes, and he tried that, but there is no improvement for that one. He was reluctant to take any medications prescribed by the GP. So how are you going to see him in the clinic, and how are you going to take his management forward?
Yeah, so I look at these referrals before the clinic. So while they're waiting, I get them to fill out an IPSS questionnaire. I do a Flowrate and post-void residual, and maybe urine dipstick as well. And then I'd review the referral, and when I go in to see the patient, I'd want to particularly focus on exploring the symptoms in terms of their duration, whether they're sort of predominantly voiding or storage in nature, any episodes of incontinence, any recurrent UTIs. I want to ask a bit about red flag symptoms, so any visible hematuria, any neurological symptoms, any nocturnal enuresis. I'd want to get a kind of baseline for their sexual function, particularly in terms of future treatments. I'd want to know a bit about any particular exacerbating factors. So what's their fluid intake like, for example? Are they constipated? I want to know a bit about the urological history. So what specific behavioural therapies have they tried with the GP? Have they tried any medication at all? And have they had any previous urological interventions? Have they had any episodes of acute retention? And then I want a sort of general idea of their comorbid status and functional status in terms of their fitness for further treatment. And I specifically ask about conditions that might affect their symptoms, such as diabetes and neurological symptoms, for example. And I'd also want to know about risk factors for bladder and prostate cancer. I then go on to examine them. So I'd sort of have a general look at them to look for any signs of renal failure, peripheral edema, for example. Examine their abdomen for scars, and palpate their abdomen for a palpable bladder, any loin tenderness. I'd examine the genitalia to look for any phimosis or meatal stenosis. And then I'd examine their prostate with a DRE to examine it for size and consistency, and also assess for any fecal impaction. And if I have any neurological concerns, then I'd examine their tone and do a full lower limb neurological examination.
Okay. And you initially said that you will do some investigations for him. So can you elaborate that further?
Yeah, so I mentioned IPSS first, so that's the International Prostate Symptom Score, and that gives me a more quantifiable idea of how bad his symptoms are, and it would just help as a baseline in terms of measuring response to further treatment. I also mentioned I do a urine dipstick, which I think is a cheap and quick and high yield investigation to look for not only infection but also non-visible hematuria or even glycosuria, which might direct further investigation. And I mentioned doing a Flowrate and post-void residual, which again can help in terms of working out whether they've got signs of obstruction, and knowing if they've got any signs of chronic retention, which would affect my further investigations and treatment.
Okay. Will you do any blood tests for him?
So it depends, really. The investigations I mentioned are kind of a baseline for most patients. In terms of doing a renal function test, the NICE guidance really recommends it for patients that have any clinical signs of renal failure. So I do that based on my assessment. Equally, with a PSA blood test, I wouldn't do that immediately. NICE would recommend that we discuss it and offer them time to decide in patients that have symptoms related to bladder outflow obstruction secondary to DP. So if that's what I'm suspecting, I would certainly discuss that with him, and I'd discuss that in relation to his risk factors, and maybe even use a risk calculator. After that, we may consider a PSA for him.
Okay. And what about any imaging test?
Again, I wouldn't routinely do an ultrasound on everybody, but I do it in specific situations. As per NICE guidance, if they've got any signs of chronic retention on my post-void residual, if the urine test shows sterile pyuria, or if they've got they say profound symptoms or any pain. And obviously, if they've got any signs of renal failure on blood, then those would be reasons I would do an ultrasound.
Okay. And will you do cystoscopy for patients with lower urinary tract symptoms?
Again, the indications would be pretty similar. The one I didn't mention was hematuria. So again, if they've got any signs of hematuria, profound symptoms, pain, sterile pyuria, those would be reasons I'd do a cystoscopy. But I wouldn't routinely do it unless it's for a specific indication.
Okay, well done. Can you tell me more about IPSS score?
So it derived originally from the AUA symptom score, which looked at 7 symptom indexes, so 3 storage symptoms and 4 voiding symptoms, and that gives you a score out of 35, and then the IPSS just adds on an extra quality of life score out of 6, and it's one of the most widely used, if not the most widely used, validated questionnaire across the world. So it's it's useful as a baseline.
Okay. And you have done the Flowrate and bladder scan for him, so I'll give you the values of that. So the Flowrate and bladder scan shows voided volume 282 mils, Q max 10, Q average 5, and post void residual of 12 mils, and it shows a obstructive.
Sorry, I think you just repeating repeating the values.
Yeah, I'll tell you once more. Voided volume 282 mils, Q max 10, Q average 5, post void residual urine 12 mils, and it shows an obstructive pattern.
Okay. He's got an adequate voided volume to interpret the trace, and he's got a low Q max. His chance of being obstructed, if it's between 10 and 15, is about 66% or thereabouts. And he's not got a huge post-void residual, but I'd be concerned that some of his symptoms are related to bladder outflow obstruction.
Okay. In which scenario you will think more of the option of having a bladder diary? The NICE guidance would recommend it if they've got storage symptoms, and I think EAU also recommends it if they've got predominantly storage symptoms, or if they've got quite significant nocturia. I think for me it's useful for a couple of reasons. One, if we're considering nocturnal polyuria as a specific diagnosis, because there are specific treatments for that. And number two, I think in terms of behavioural modification and assessing their fluid intake and type, I think it's useful for that reason. And number three, in the future, if we're considering urodynamics, it's nice to know what their functional bladder capacity is. It gives us information about that. And in which conditions do you do urodynamics in lower urinary tract symptoms?
So I wouldn't routinely do it on everyone. We've seen from the upstream study that that's not necessary. But the EAU has specific recommendations. So extremes of age, if they're less than 50 or more than 80, in terms of their flow rate. So if they're not able to void more than 150, or if they've got a post void of more than 300 mils, or if they've got predominantly voiding symptoms, but their Qmax is still high, I think more than 10. or if they've had previous outflow obstruction surgery and their symptoms are persistent or recurrent, then that's a reason to do it. And I think lastly, if you need to specifically know about the underlying pathophysiology, then it's useful. I think things like neurological conditions, it can be useful.
Okay, are there any derivatives in the urodynamic parameters that will help you to pinpoint that there could be a bladder outlet obstruction?
There's a bladder outflow obstruction index with the Abraham-Griffiths number, and that's calculated using two metrics: is the p-det at Qmax and the Qmax. So the equation you use is p-det Qmax minus 2 times Qmax, and that gives you your index. And the ranges you then use are if it's less than 20, then they're unobstructed. If it's more than 40, then they're obstructed, and between 20 and 40, then it's equivocal.
Okay. And what is bladder contractility index?
That's another index that was developed by Paul Abrahams, and that looks at the contractility of the bladder, to choose a contractility, and that's calculated again looking at the p-det at Qmax, and you then add that to 5 times the Qmax. And if it's more than 150, that's hypercontractile. If it's less than 100, then it's hypocontractile. If it's between 100 and 150, that's normal.
Okay, well done. So this patient, when you examined him, he has no palpable bladder, no neurological disorders, and his prostate is moderately enlarged, benign feeling prostate. He informed you that he had a men's health checkup and he had his PSA done 6 months ago as part of it, and it was 1.2. And I have already given you the Flowrate and bladder scan study. IPSS, it is voiding predominant symptoms with 15 plus 4. What is your diagnosis here, or working diagnosis?
So based on his IPSS score, he's got moderate lower urinary tract symptoms. Based on his flow rate, there's a reasonably high chance that he's obstructed. So I think he's got bladder outflow obstruction secondary to benign prostatic enlargement. Clinically, it feels benign.
Okay. So he's 62-year-old. What do you think is the prevalence of BPH in that age group?
So there are studies that have looked at prevalence as the age groups go up. The most prominent one I'm aware of is the Olmsted County study. And I know that in the age of above 70, the incidence is about 28%. So I imagine it would be close to that for someone who's 68 years old.
Okay. And coming to the Olmsted County study, do you know regarding the risk of AUR for this patient who's having moderate urinary tract symptoms?
Yeah, so there's a few metrics that you could look at. His the boxes that he would tick would be his IPSS. So if it's more than 12, his I think a Qmax of less than 10, I believe, is a risk factor. So his is a little bit higher than that. I think the IPSS would be the main risk factor. The other ones that it would mention would be a PSA of more than 1.4, which he doesn't have, an age of more than 70, which he doesn't have, and a post-void residual of more than 50 mils, which he doesn't have. But based on his IPSS score, he I think about double the risk of retention.
Okay. So yeah, based on the Olmsted County study, there are 6 predictors of BPH progression. You studied nicely. The Qmax is it's from this study that magic number comes 12. So Qmax less than 12. You can say IPSS, but as you said before, it was the predecessor of the IPSS called the AUA-SI symptom index.
Yeah.
If it is more than 8, that is a predictor of BPH progression. And PSA, you rightly said, more than 1.4, increasing age, and also the prostate volume more than 30 cc. So your GP has already advised him, or he advised him regarding behavioral modification. So he has gone through all those things like double voiding, timed voiding, avoidance of caffeine, nighttime food restriction, but it hasn't improved anything, and he thought that he will see a specialist before having any treatment options. So at this point of time, how are you going to manage him?
So it sounds as though he's tried most of the behavioural options that I would have suggested. So I talked to him about the further options of medical management, and also talked to him about surgical management as well. But I'd probably start by talking about medical management in the form of tamsulosin, given that he has moderate symptoms in line with NICE guidance. And I talked to him about what the efficacy is of it, and what the side effects are of an alpha blocker.
Okay. Will you consider the option of 5-alpha reductase inhibitor at this time?
I would. So again, I think the NICE guidance suggests it for men who have a prostate volume of more than 30 cc's or a PSA of more than 1.4, and he has one of those things, along with risk factors for progression, which he does have. So he would be a candidate for dual therapy. But again, I'd have to talk to him about the side effects, some of which may or may not be acceptable to him.
Okay. And you said that you will counsel the patient regarding the side effects of alpha blockers. Can you tell me in more detail how would your counseling would be?
So I'd particularly emphasise the risk of ejaculatory dysfunction, so that he is likely not to produce any ejaculate while he's on it. There's a risk of postural hypotension, asthenia, and if he's got cataracts and he has further surgery, then there's a risk of intraoperative floppy iris syndrome. I think that very rarely there are risks of skin reactions as well. But those are the main things I would discuss with him.
Okay, and what are the side effects of 5-alpha reductase inhibitors?
So again, I'd mention the sexual side effects, so loss of libido, erectile or ejaculatory dysfunction, and I'd also talk about the small 1 to 2% risk of gynecomastia as well. Okay.
So if you are giving him finasteride based on his moderate symptoms and the prostate volume, what is the evidence to add finasteride for bladder outlet obstruction due to BPH?
So just finasteride specifically, there's a few studies. The PLES study looked at just finasteride on its own versus placebo. That study that was done in 1998, looking at over 3,000 patients. And it found, the primary outcome was looking at IPSS, and there was a greater improvement in IPSS score of 3.3 versus placebo at 1.3. But the secondary outcomes of acute urinary retention and need for surgery showed a relative risk reduction of 57% and 55% respectively, I believe. So finasteride was effective for all those parameters. There's also another study that looked at finasteride along with combination therapy and comparing it against alpha blockers. So it was finasteride, doxazosin combination and placebo, and that study was the MTOP study. And again, it showed that combination therapy reduced what was effective at reducing IPSS, but was also effective at reducing the need for further surgery and acute episodes of acute retention. I think about 67% in terms of reducing the risk of progression for combination therapy versus monotherapy. Finasteride alone in that study did reduce the risk of acute retention and need for surgery, but doxazosin didn't have any prolonged effect in that regard.
Okay, well done. And what about, will you give anticholinergics? Or what is your rationale to prescribe anticholinergics in bladder outlet obstruction due to BPH?
Yeah, so I wouldn't routinely, but if they've got significant storage component to their symptoms and there is evidence for it, the trial I'm aware of is a Times RCT by Kaplan et al., I believe, and that was looking at tolterodine 4 milligrams extended release and comparing it against tamsulosin, combination therapy, and placebo. And their primary outcome was looking at patient-reported symptom improvement, and it showed an 80% symptom improvement for combination therapy for patients that had LUTS along with frequency or significant urgency. And the main thing sometimes you worry about is whether it will push the patient into retention. But actually that study showed that only I think 0.5% of patients who are just on tolterodine alone went into retention. But these are all patients that had low post-void residual. So the EAU recommends it. If the patient's got a post-void residual of less than 150 mL, then it's a fairly safe thing to give if they have those symptoms.
Okay. And what's the role of phosphodiesterase inhibitors?
So there is some evidence for their use. It's specifically only for tadalafil. There was a study by Don Tucci et al. Looking at tadalafil versus placebo, and it does have some effect on Qmax and on nocturia. That was only over a year, and I think that's the only study that's available. So the evidence is quite limited, and obviously it's an expensive drug. So NICE don't recommend it as a monotherapy for LUTS alone. It's just not a cost-effective option. I think EAU recommends it in certain circumstances, but I wouldn't give it unless the patient presents with ED and they've got LUTS as well. That would be a reason to use it for me.
Okay, so your gentleman listened to you and he felt that he hasn't tried hard enough regarding the lifestyle modification. So his current he prefers to continue or even try hard on the lifestyle modifications. So he's asking you what all complications can happen with a benign prostatic enlargement causing LUTS without treatment.
Complications, so over time it can progress, so his symptoms can get worse. He can get recurrent urinary tract infections, he can get hematuria, he can go into acute retention, he can progress into high pressure chronic retention and develop renal failure, he can get bladder stones.
Okay, so you were on call, you are the on-call consultant, and your registrar is going through the post-take ward rounds. And now, when you are doing the ward rounds, you saw this patient who came to A&E in the early hours with acute urine retention. The A&E team has inserted a catheter, and it was 1.2 liters painful retention, and his pain improved after insertion of the catheter. So you know him well now. You have already examined him. So how are you going to take his care forward from here?
So I've already assessed him, but I think the key things I would have wanted to know, apart from his neurological status, would be if there's any signs of renal failure and what his blood showed.
Mm-hmm.
And I'd have also examined his prostate, so I'd want to know what that showed as well. Have I already assessed him?
Mm-hmm. What's the difference between a spontaneous acute urine retention and precipitated acute urine retention?
Precipitated refers to an underlying cause which is pushed them into retention, such as infection or constipation or postoperatively, for example, whereas spontaneously means there is no precipitating factor. And that's important in terms of determining their risk of further failed TWOCs or further progression to need surgery.
Mm-hmm. And what percentage of patients with spontaneous AUR required surgery?
So the study I'm aware of is the AL4 study, and that was a study looking at patients who've gone into retention and the efficacy of tamsulosin versus placebo in those patients. But ultimately, for the patients that passed their TWOC and were then followed up for 6 months, who were randomized between tamsulosin and placebo, I think overall at 6 months about 36% of them ended up needing surgery. So that's why it's important to follow them up.
Okay, and in the initial phase of the study, what was the success of TWOC with tamsulosin?
It was around 60%, just over 60%.
Okay.
For patients who were twapped after 3 days on tamsulosin, versus I think 48% for ones that weren't.
Okay, well done. 62 versus 48. So, and what was the alpha blocker used in ALFOR study?
So I said tamsulosin is actually alphazocin. Sorry.
So, this patient is there in front of you. How are you going to? What's your plan further?
Yeah. So sorry. Do we know what his renal function was?
Yeah. Sorry. His renal function is normal. His DRE is similar. He hasn't taken any medications yet. Clear urine, no hematuria. He's completely comfortable now. No precipitating factors, no constipation, no UTI, no binge drinking.
Okay, fine. So it sounds as though has a spontaneous episode of retention. He's got a very large residual of more than 1.2 litres. So both of these factors put him at quite a high risk of failing his TWOC. However, I think it's still I don't think there's any harm in doing a trial without catheter, providing his renal function was normal. So I would still offer that. I would, based on my examination, I'd start him on an alpha blocker, a tamsulosin, and I would bring him back to see us for his trial without catheter, and we'd do a post-void residual on him. And if he fails his trial without catheter, then I would commence him on intermittent self-catheterization. The morbidity from that is a lot lower than having an indwelling catheter. And at a post-void residual of that amount, if he fails his TWOC, I'd want to do, if he's considering further surgery, I want to do urodynamics prior to counselling him on that.
Okay. So if you're prescribing him tamsulosin, after how many days will you offer the TWOC?
After 3 days, ideally.
Okay. And what's the evidence for that 3 days?
So although the success rate of TWOC does get higher as a period of catheterization increases, there was another study called the Rett and Wells study by Fitzpatrick and Emberton, and that was done across many different countries, and that showed that after 3 days the morbidity and hospitalization stay increases quite significantly, whereas the rates of successful TWOC are reasonably high at 3 days, so that's an optimum time to do it.
Okay. And if a patient on tamsulosin fails TWOC at 3 days, what will be your option? Will you offer a second TWOC or discuss within the option of surgery?
It depends, as we said before, whether it's spontaneous or precipitated, and what the patient prefers as well. So I think if the patient was not keen on trying any further medication, and there was no precipitating factor, it was spontaneous, then yes, I would talk about surgery with them. But if there were other precipitating causes, then I want to treat those first. And the other option may be to add in a 5-alpha reductase inhibitor, and maybe try a trial without catheter in a few months' time, once that's had time to kick in.
Okay. And how long it will take how long it will take the 5-alpha reductase to act on the prostate?
It can take up to 6 months. So it depends if the patient's willing to have a catheter for that long.
Okay. So your gentleman came back. He had his TWOC done. His TWOC was successful. He still doesn't want finasteride because he's sexually active, and he just wants to continue on tamsulosin only. How are you going to plan his follow-up?
So I want to see him again in clinic in about 6 months' time, and reassess his symptoms, reassess his flow rate and post-void residual, and take it from there, in terms of whether he needs any further treatment or not at this stage.
Okay. And generally, what are the indications of BPH surgery?
Generally speaking, if they've got ongoing bothersome urinary symptoms despite maximal medical therapy or not willing on further medical therapy, if they're catheter dependent from recurrent episodes of acute retention, if they've got high pressure retention, and if they've got ongoing visible hematuria from BPH, if they've got bladder stones from bladder outflow obstruction, or if they've got recurrent UTIs from high post-void residuals.
Okay, well done. So we will stop this session now because this was planned for the medical management of BPH LUTS. So
Okay.
how do you think it went?
Covered quite a lot, but yeah, it was okay.
It was excellent, I would say, because your thought process is really good, and it is very you put it in a very systematic way, and also you know all the evidence behind your recommendations to the patient, which is really good. I have done this recording and I have put the slides along with that one, so it was just along with the slides that you are going. So well done. And any questions, anything that you want to ask?
Yeah, I wasn't entirely sure if I gave the right answer with the second TWOC question.
Yeah, so
what is the ideal answer for that?
exactly. So that was again from the Fitzpatrick study. So
Okay.
in that one, so if there is a TWOC failure, what they found out is that if you try for another TWOC, the success rate is around 30%. It's exactly 29.5% in the Fitzpatrick study. So
Okay.
if there are other comorbidities, patient doesn't want any surgical options at present, then there is a role for a second TWOC, but we have to tell the patient that the chance of success is around 1/3 only.
Okay.
So that was the one, and because I got that question during one of my mock vivas.
Oh, really? Okay.
So I didn't know that, but when I went through the that paper again, then I realized that there's a good point of that one.
Yeah, I'll have to read that again, I think.
Yeah, and Times trial, well done, because that's the one that compared tolterodine and tamsulosin. But sometimes the question can be, is there any other trial that has done with tamsulosin and solifenacin, because that's the most common combination that we use, isn't it? Then you have
Yeah.
do you know about that trial?
No. Which trial is that?
It's the Neptune trial.
Okay, Neptune trial.
Yeah, it's by the Bristol team, so Mr. Drake's team. And
Okay.
there are 2 phases for that study. So I would suggest to read the Neptune trial as well, in case if it is asked for the anticholinergics.
Okay, I'll look that up.
Yeah. And one of the questions asked is if there is any significant post-void residual. So one of the, not the contraindication, but one of the caution to add anticholinergics for a storage predominant symptom is EAU guideline says that to avoid it if the post-void residual is more than 150 mils.
Yeah.
So that could be a good one. And yeah, no, your numbers were really good. And again, when you say nice guidelines, I would always suggest to say, because we know that in the LUTS guidelines it is 2015. It's like the prostate if you are saying about the prostate guidelines, it's always nice to say in the way like nice guidelines 2021 or update 2021, things like that. So you know that what's the timeline of that guideline, and because we know that it's time to change it as well. So we sometimes we have to go out from the nice, especially regarding the newer therapies. So when you say, I mean, you put it nicely. I'm just saying it to push, because you have the potential to go like 7+ to up to 8. So to reach that level, if you say that nice 2015, then know that you are aware of the timeline of the guidelines as well.
Okay, perfect.
And one of the other questions that can be asked is the role of phytotherapy. So you can read about. I have put that in a slide in this recording, so you can read about it. And that question I asked regarding the predictors of BPH progression from the Olmsted County study. That numbers should be thorough.
Yeah.
Exactly.
need to go over that again.
But overall, it was an excellent performance. Well done.
Thank you. Thanks.
So we'll meet again for the surgical BPH part.
Yeah,
And
perfect. Thank you very much.
you're welcome, and best wishes with your preparation.
Thank you. Thank you.
Bye-bye.